The name of today's game is engagement. Seriously, if you're watching this, I need you to comment, answer questions, and share your thoughts. Not because I want validation, but because the YouTube algorithm only pushes videos that get interaction. So if you find even one thing helpful, help push this to another rad tech by dropping a real comment, not just B or C. Go a little deeper. We're building a learning space here, not just checking boxes. Today's focus is the 4-view shoulder series every tech should know: AP external rotation, AP internal rotation, scapular Y, and the Inferosuperior Axial or Lawrence view. Let's go. Before we jump into positioning, let's ground ourselves in shoulder anatomy. Every image in this series is only as good as your ability to identify these structures. Here's what you need to recognize on every image: the acromion, that's the bony hook at the top; the coracoid process, that sits anterior and medially; the glenoid cavity, that's the shallow socket of the scapula; the greater tubercle, that's the lateral bulge on the humerus; the lesser tubercle, that sits anterior and medially; the humeral head, that articulates with the glenoid; the scapular body forms the base of your Y view; and the clavicle crosses the shoulder joint superiorly. So which of these do you struggle identifying the most on X-rays, and why? Let's normalize learning curves, you all. AP external rotation is your default view when trauma isn't a concern. The patient is erect or supine, and the arm is externally rotated with the hand supinated. Make sure the epicondyles are parallel to the IR, and the CR is 1 inch inferior to the coracoid process. This view projects the greater tubercle laterally and should show a clear glenohumeral joint. So here's a pop quiz for the comments. Why is the greater tubercle best visualized in this view? And what happens if the arm isn't rotated enough? On a proper AP external, the greater tubercle is in profile, the humeral head is rounded and smooth, the glenoid fossa should be partially open, and the clavicle lies superior without overlap. The acromion is visible laterally. Some common errors include something like no tubercle in profile, you're probably under-rotated; overlapping joint space, you might need to recenter. You should use a grid and use 70 to 75 kVp in good collimation. Now we flip it, AP internal rotation. Your arm is rotated internally where the back of the hand is against the hip or thigh. Now the epicondyles are perpendicular to the IR. The CR remains 1 inch below the coracoid. This view highlights the lesser tubercle, and the humeral head appears more rounded with subtle differences. Here's your comment challenge. What pathology might be missed if you forget to do this view, and when would you avoid doing it altogether? On a solid internal rotation view, you'll see the lesser tubercle medially in profile, the humeral head slightly overlapping the glenoid, the clavicle and acromion still visible, and the scapular borders visible. The coracoid seen in face. The biggest mistake here, doing this view on a dislocated shoulder. It hurts and gives you nothing diagnostic. In trauma, go neutral and move on to your Y view. All right, the trauma MVP, the scapular Y. Position the patient PA and rotate them 45 to 60 degrees towards the affected side. The arm stays neutral, there's no rotation, and the CR goes to the scapulohumeral joint. This view creates a Y shape. The acromion and coracoid are the arms of the Y, and the scapular body is the tail. The humeral head should be centered over the Y stem. Quiz time. If the humeral head is displaced under the coracoid, what kind of dislocation is it, and how can you tell? On a clean Y view, you should see the acromion, that's the upper lateral arm of the Y, the coracoid process, that's the anterior arm of the Y, and the scapular body forming the tail. The humeral head should be centered in the Y, and there should be clear lateral and medial scapular borders. Look out for under rotation. It flattens the Y. Anterior dislocation, the humeral head moves under the coracoid. Posterior, it's under the acromion. You want to use a 75 to 80 kVp with a grid for this view. The Lawrence method is a horizontal beam axial projection. The patient is supine and the affected arm is abducted 90 degrees externally rotated. The IR is placed against the neck. The CR is directed horizontally through the axilla toward the AC joint. This view shows the glenoid humeral articulation clearly and is great for evaluating Hill-Sachs lesions or the labrum. All right, here's your engagement challenge. Explain in your own words why abduction is the key here and what your backup plan is if the patient can't tolerate it. On a good axial shoulder, you'll find the glenoid cavity in face, the humeral head fully visible, the coracoid and acromion form an arc above, the clavicle is seen superior and slightly posterior, the lesser tubercle is anterior, and the greater tubercle is posterior. There's no grid needed. Use tight collimation, a 65 to 70 kVp. If the patient can't abduct, consider a Clements, Nakayama, and that's your 4-view shoulder series. AP external, AP internal, scapular Y, and Inferosuperior Axial. Here's your final comment prompt. Which of these views gives you the most trouble, and what's your go-to trick to get it right? Drop it in the comments. Like if this helped, subscribe if you want more ARRT breakdowns like this, and share it with your study group. We're building a smarter, stronger RadTech community, one video at a time. Want more? Check out my PDF in the description for an outline of all my ARRT videos. And drop a comment. Let me know which one you found the most helpful, if you want more quizzes, or if you want more Canva outlines. And hey, did you also know I've trained a custom GPT just for you? It's called ARRT Study Coach Analyze with Casey. It's like having me in your pocket 24/7. Whether you're brushing up for the ARRT boards, EQR, or recertification, this GPT is built to break it down in plain language, quiz you, and guide you all the way to passing. See you in the next episode.